It's 2 o'clock. We're going to get started on the next session. Thank you for participating in TCTAP. I'm Lawrence Garcia out of New York City. My co-moderator is Horst Sievert out of Germany. We also have on panels the physicians, Doctors Choi, Chung, Go, Higami, Kang, Kim, Ra, and Won. Our session will be a live session from Seoul National University. Dr. Chae, who will be performing an EVAR, endovascular aortic repair procedure. If we are ready, we can go to Dr. Choi.
Good afternoon, ladies and gentlemen. This is Seoul National University Bundang Hospital. My name is Yoon. I'm working with Dr. Chae, Chae. Chae is now dressed up, so I will introduce our case first. Before proceed our EVAR, we should check the coronary artery of this patient. So we are performing the coronary angiography now.
Is that your routine in all cases to check the coronaries?
Not the routine procedure. Good afternoon, Professor. So please introduce our team first.
Okay. Yes. Just a moment. Okay. As I told you, I'm Yoon, and on my right, Dr. Seung-Woon is a cardiologist and also intensivist in our hospital. And on his right, Jae-Uk Shin, our fellow, and he's helping us too. Okay,
Yes,
that's our team.
Yeah. Good afternoon. I'm Chae. Actually, today I prepared two cases. One is EVAR, the other case is TVAR case. But unfortunately, the patient had a thoracic aortic aneurysm patient. He refused to join the live demonstration. So today we will do the only one case. So we have a lot of time to discuss. And first of all, you asked, is it a routine procedure to check the coronary angio first? So not a routine, but this patient is a 69 years old gentleman. So there's a high possibility of having coronary disease other than abdominal aortic aneurysm. So now we are checking the coronary angiogram.
We don't see the fluoro screen yet.
Yes, fluoro 보이게 해주세요.
Yeah.
Yes.
Oh. His aorta is very tortuous and long. Is this L5 or R5? 6, please. JR6.
So do we have some of the
JR6 주세요, JR6.
do we have some of the history of this patient as well?
Okay.
Yeah.
During the coronary angiography, our fellow Dr. Shin will present our case. Please show the case slide.
Hello, my name is Jae-Uk Shin. I'm a second-year general cardiology fellow at this hospital. The case number is 40, performed at Seoul Bundang National University Hospital in South Korea. The main chief operator is Chae, and he is Dr. Yoon, professor in this hospital. And behind the right side is Seung-Woon, and I am a fellow. Okay, I will briefing this case of summary. This is 1960 years old male with hypertension and dyslipidemia. His initial chief complaint was chest pain, but the coronary disease was insignificant at that time. During regular follow-up, infrarenal AAA was incidentally founded in 2022. The diameter of the abdominal aneurysm at that time was 5.3 cm. It was gradually enlarged to 5.5 cm by 2024. We determined the EVAR is one of the most appropriate options of this case. Okay, his medical history, he has no MI history and no PCI history, only just has some insignificant coronary artery disease. Next, please. He has hypertension and dyslipidemia and has no diabetes and no family history. He was an ex-smoker, 35 years, and he has another aneurysmal dilatation of ascending aorta. The diameter of ascending aorta is 4.3 cm, and anyway, it is stable over time. He presented with atypical chest pain at first I mentioned. Coronary was insignificant. Anyway, instantly founded on infrarenal AAA during workup. Next, please. Echocardiography finding. Normal average systolic function and ascending aorta diameter is 46 millimeters, and the other valve function and dimension is insignificant. The treadmill test is negative, and there is no significant perfusion defect on SPECT. ABI is also within normal range. Cardiac catheterization was not performed in this case we are doing now. Next, please. Today's target lesion is infrarenal abdominal aortic aneurysm occurs. And second, the distal aortic.
Yeah, okay. So is there any comment or question about the patient history?
Yeah, I mean, I 100% agree with all what you said, but a surgeon could say, well, this patient is extraordinarily young, no diseases, good surgical candidate. So did you have that discussion in your hospital, or is it straightforward towards EVAR?
Yes, I already discussed the surgeon, and then also the patient and patient family. The patient wanted to do the EVAR procedure rather than surgical repair. This patient actually last year his diameter of abdominal aortic aneurysm was 54, but right now the aneurysmal size is 59. I'm going to show you the CT angiogram. It's checked yesterday. And then this in CT angio 보여주세요. Okay, yeah. As you can see here, his aorta is very diseased, and especially in the ascending aorta arch, you can see the very ugly plaque, and then 밑으로, and there is a small aneurysmal change around here. Yes, you can see some thrombus, and then 내려주세요. Yeah. Yeah. This is around the celiac trunk. So there you can see the thrombus inside the aorta. And then next. Okay. This is the diameter measured today. It's 59 millimeter maximum. Okay. So this patient is a good candidate for EVAR, but also you can mention about his age. The 6'9" gentleman is a very young age, so it's debatable. Surgical correction is better than the interventional procedures.
So you are a cardiologist, right? Not a surgeon.
Yes.
Yeah, okay.
Yeah,
Just to make sure.
Yeah. Yeah. Okay.
Otherwise, you have to debate with yourself. Yeah.
Yes.
Can we see again? I didn't really see the neck, the infrarenal neck. Maybe you can show that again.
Good.
The length of the neck.
위로. Yeah. So I'm gonna show you the measurement sheet. PPT로 바꿔주세요. PPT. Yeah.
Next.
Next.
Oh yeah. Okay.
Measurement.
Yeah, it's very long.
요거 전 주세요. 전. Yeah. Okay.
The neck is too long, right?
Yes. So proximal neck length is long enough to do the EVAR, and there's no IFU outside the IFU. But the most the considering point is next thumb. Yeah. So distal bifurcation area. So is it big enough to do the EVAR procedure?
Yeah.
So regarding the distal bifurcation area?
We don't see the diameter there, but I mean, even if it is narrow, you can still balloon it, right?
Yeah,
Okay.
at the division, it was about 18 millimeters. Was it 16 or 18 millimeters?
The length was 18, no?
Oh, the length, I'm sorry.
Dr. Chae, this is Dr. Ra from Korean University.
Okay. Yeah.
Good to see you.
Good to see you too.
Yeah, the three-dimensional and the CT angiography shows there's some focal calcification in the distal bifurcation. So
Yes.
you mean the smallest size of distal aorta is 16 millimeter?
Yes, actually, it is very difficult to measure exactly
Yeah,
the
that-
diameter of a bifurcation.
They cannot be
So-
exact. So
Yeah, yeah.
one option is to the evaluation. This kind of ambiguous distal diameter, I'm doing separate process, and also I can see, so the CT angiography, the left renal artery or osteostenosis looks like. So in this kind of pre-procedural, I'm usually doing the separate procedure for diagnostic coronary angiography, renal, and also exact determination of this, because this you are preparing the endurance too. That maybe sometimes 60 millimeter is not so good choice for this relative bigger device. So last week I had one case who had 15 millimeter distal aorta. So we have two other options. One is the old version from the Codis, and the second version recently launched to Korea, the Minos from the Microsoft, Microport from China.
Microport, yeah.
Yeah. So last week I implanted the 15 millimeter with the two slender rim with the 14 French bilateral. So that was accommodated nicely for the slender distal aorta. So I'm not sure the 60 millimeter can be easy with the current Endurance 2S. I will look at the procedure. What is your opinion? So sometimes the iliofemoral conduit is slender and distal aorta is too not so bigger to accept two iliac stent graft. Maybe we have a good choice is the slender device.
Yes, it's a good option for the narrow bifurcation area, but the slender device itself has a weak scaffolding power, so there is a high chance for the limb narrowing, and then so this device maybe overcome that kind of things, and then. If there is a limb occlusion or the deformity, I will do the kissing balloon angioplasty in the iliac bifurcation area, or putting bare metal stent, kissing bare metal stent around the bifurcation area.
Can you show us the plain CT? Because here we see just
Okay.
a lot of calcium, but it's not clear how
Yes.
much this is
Yes.
really obstructive.
Yes. CT 보여주세요.
So in
Yeah,
the
go 밑에.
in the U.S.,
Okay.
for this
Yeah.
kind of distal bifurcation, once you put the
Yeah.
stent in, you crack it with just, with a coda balloon.
거기
The
bifurcation
Look here,
alternative
there's
would
no
be to
calcium. There's
preemptively
almost-
treat with shockwave. That
Look
would
here,
crack
there's
that
no
distal
calcium.
bifurcation.
Okay.
Look here,
Stop.
there's no
Yeah.
calcium.
So would you lower the contrast? We can see
To
the
see the calcium.
calcium.
저기 컨트롤.
What you can show us the
Contrast
venous
doesn't-
image. Venous.
Yeah, it'd be nice if they made it less.
Yeah.
pacify,
Yeah, yeah,
just to look at
yeah.
the calcium.
But it's not a lot. I mean, you see some, when he
agree.
moves up, there are some calcium deposits, but it's actually minimal calcium.
네, 헤파린
I honestly don't. I think it's going to be okay.
컨트라스트를 줄여. 아니 여기. 예.
The 하운스필드 유닛을
올려서
줄여달라.
올려. 바이포케이션까지 올리고.
There you go.
오케이. 예. 오케이.
Okay, minimal.
Yeah.
Yes. Can you see the calcium?
Yes.
See it
Yes.
better now. Yeah.
Yeah.
Go up, please.
Show the true bifurcation.
Go down,
CT
go up a
조금만 더
little bit.
올리세요. 조금만 더 위로.
메인바디,
예, 오케이.
메인바디 준비하세요.
보기 예.
메인바디.
오케이.
It's not obstructive, right?
Yes.
And the femoral artery has enough space, right? Femoral
Yes.
artery is good.
So this kind of once you do aggressive kissing balloon angioplasty, some chance of injury, major injury.
So presuming that this is going to be big enough, what are your thoughts in regards to placement for ipsilateral and the contralateral gate? How do you want to proceed here?
엔저 찍었어.
네.
엔저 돌려보세요.
Okay, let me show you angiography first. 엔조 화면으로 바꿔주세요.
오케이.
Okay, this is our first angiography. Luckily, there is no significant stenosis in his coronary arteries, so we safely proceed this procedure. And this is the angiography. And so we are going to insert the main body through the right limb, and then there is a tortuosity from the left iliac artery to aortic aneurysm, and then especially there is a narrowing in distal leg. So we are going to insert both limb at ballerina position, so a little bit. That's our plan.
Left renal artery is okay.
There is a stenosis there, so we should be very careful. But unfortunately, the right renal artery is lower than
Looks right renal lower.
Yes. So I hope we don't touch the renal artery ostium.
So actually, even though the renal artery ostium of the left renal artery has disease, but it's around 50% stenosis in the angiogram. But this patient, clinically, there's no resistant hypertension, and also his creatinine level is normal. So I don't think we're going to touch the renal artery stenosis.
Angiography itself looks like a reverse conical shape, so maximum adjust to the right lower renal level will be important to
Yes.
prevent type 1A.
Yeah.
Yes.
What's the
PowerPoint
center?
보여주세요. PowerPoint.
If I could ask, what's the center line distance to the bifurcation from the lowest renal? Is it 10 or 11 centimeters?
Okay.
I can't tell.
Okay, down. Oh yeah, yes. This is sizing sheet and then measurement. So you can see the 29 millimeter long from the right renal artery to the proximal part of aneurysm.
Okay.
So now we are going to insert the main body.
How did you prepare the groin? Are you using ProGlide or
Yes.
yeah, one or two?
Two, both two.
Actually, sometimes one good option is to the unibody plus pen bypass to get the maximum distal dimension.
레퍼런스를 좀.
But this patient's distal aortic bifurcation area, the diameter is more than 14. So I think just the standard EVAR procedure is good enough for this patient. And then, but the only concern is that this patient is very young. So in the near future, the aorta may be remodeled. So I think in this patient, we have to do the ballerina position of the EVAR device is test.
Which wire are you using? Which wire?
Is this a Lunderquist or something else?
The left undercast and the right.
And are you using AP projection or are you adjusting according to the CT scan?
We are using the AP projection now.
Always or just in this case?
Sometimes we adjust, but this case we can use this
Pretty
angle.
straightforward, yeah.
Yeah.
Yes.
At some point, they'll get rid of the parallax and make sure you're at the level of the renal.
To see
Yeah,
the
sure. Usually left linear artery is lower. In this case, the a little LAO and then a little cranial view can easily see the left renal artery ostium.
Can you show us the markers you are looking for? The markers on the device?
Okay, so marker is the after the cone, next to the cone, the first marker is there. So,
And the-
주민 좀 해줘.
Contralateral limb, the orifice?
Yeah.
Okay.
Yes, so
Contralateral limb orifice audit.
Okay, it's here. It's in the center now, and then but I will rotate a little bit to the 11 o'clock or 10 o'clock. Now it's 10 o'clock.
I mean the marker on the screen, how it comes up.
Okay. So marker on the screen. Okay, when I rotate there, there is two markers. It's just proximal to the sheath, and then you can see the marker is rotating.
Yeah.
Yeah, there- the
Now
gate's
it's
on the
right on the right, and then now it's in the left. Okay, so I put like with this position. Okay,
So now it's in the middle, no?
middle.
the
Okay.
primarily,
Now in the-
I'm routinely doing the LAO, mild LAO cranial projection to see the proximal marker in one line to adjusting the renal level. So from the beginning, it's better to start with the little LAO cranial instead of AP.
Okay, LAO 10, cranial 10.
Dr. Chae, is there any particular reason to you choose this contralateral invocation for the ballerina?
Yes, I told you that this patient is very young, so his aorta may be remodeled during next 10 or 15 years, and then there will be the high risk chance for kinking of the limb. So in this case, I usually use the ballerina position.
Wait a second before you deploy. Where is the side arm, the contralateral side arm, and where is the marker for this?
Contralateral marker.
Marker. Now it's
Yeah, I mean the marker
inside.
on the handle,
the
but I mean the marker on the device. on the-
Fluoroscope.
you mean the gate?
It's a L5 upper marker. You can see the marker.
So does that mean that the marker is on the right side?
Yes.
Don't have it on the left. Do you want to have it on the left side?
Contralateral limb marker should be on the right side, for the ballerina position.
Okay.
Okay. So I'm gonna deploy the proximal parts of the main device.
Check.
So for the main
And then,
body deployment, how
test
many of
out.
us use
And
floral
these are
mass? The floral mass
AP 로
system,
볼까요?
kind of
다시. 예.
Okay,
we use it all the time.
I will
It's
take
really
an angiography here.
a nice way to see the
잠깐만,
argent,
LAO,
mark
LAO
it, just
10,
know where
10,
the argent starts.
And then
You can
angiography 저기 subtraction 말고.
You can deploy at least one segment to see the expanded marker in one line. Otherwise, the contrast injection
Yes.
cannot identify clearly. So a little more
Yes,
deploy to see the proximal marker in one line.
Okay. Now the distal
Yeah, up to 2 segments you can move. So at least 1 segment should show. Okay.
Okay.
Then try to adjust in one line in
okay.
particular.
I will take an angiography here. Okay. 시네.
It's too high.
Yeah, it's very high.
Too high.
That's the SMA.
Right side. Okay. Yes, it's very high.
So Dr.
No,
Chae, your
위에가
intention is
하나가
the
Ma-
half
marker-
ballerina.
Yeah, marker
Not
is
full
not in
ballerina.
line. So maybe areocranial more to see the marker.
컨트롤레터.
So it's right in the heart of that L2.
Still too high. Huh?
L2. 또
조금만 더
익숙하네.
조금만 더 빼볼게.
네.
Deploying it there would be make it very interesting.
시네. Now it's
No, it's
too low.
too low. Yeah.
Yeah.
It's the upper part of the L4. It should be around here.
Correct.
Okay. Test again.
컨트롤.
Still not in one line. I'm aggressive.
Okay.
Sometimes you
조금만
put
더
a
올려서,
catheter
조금만.
into the renal.
더 올려보세요. 더. Right. And 내리고 다시 내리고.
레프트.
넘어갔다.
Okay.
That's,
okay.
that's it.
A little bit upper. Okay. Yes. Now, Dr. La, are you satisfied now?
Bingo.
Okay.
I satisfied. Okay.
So Dr. Chae, what is your preference
I will
to
check
cover
again.
all the area just below the renal artery, or just enough area to seal the proximal part?
Below the renal artery.
Yeah, you'd like to cover all the area just below the renal artery.
Yes.
And you are now in the half ballerina position, right? Not full ballerina.
Yes.
So
Not-
the
not full
side
ballerina.
branch opening will be open maybe in the posterior side of the
Test. Okay.
aneurysm.
좀 위로 올라갔어. 잠깐만. It's a little bit going upward, so I pull it down.
거기서 난 움직이면 안 돼. 또 풀.
Yeah. Okay.
What is the blood pressure now?
It's a 134.
Here comes the gate.
오케이.
There you go.
Okay.
That's what I meant. Now the leg is on the other side. Huh?
Exactly.
Okay.
Gate's gonna be hard to handle.
위에 거.
Okay.
베어 메탈 풀게요. 베어 메탈. 다 돌리세요. 오케이.
Okay.
플로로 저장하고.
Save. Okay. Now.
와이어.
와이어 테르모. I'm gonna pull the pigtail out, and then I will insert my wire into the contralateral limb.
We used to use the angulated catheter, JR or the Cobra or for the rewiring. Recently,
Yeah,
I started to use the Navisil, the steerable guiding tip, 6 French, that is targeted to the near the ostium of the contralateral os. That was very convenient to rewire within 3 seconds. So I think that is available in Korea now, Navisil, the steerable guiding tip.
But in this patient, the contralateral limb opening is the the left anterior position, so we can. I think it's easy to rewire through the contralateral opening.
Oh, Dr. Yoon can do within 5 seconds.
I hope so.
Did you give heparin and are you controlling ACT?
Yeah.
We introduced the heparin at first, and then after 1 hour, we also control the heparin dose with ACT. Okay. Talk.
With this angulation, it's very easy to introduce wire through the contralateral limb already.
Already in.
Fantastic.
Save.
It was 4 seconds, right?
That was, I wish they would have taken
less than
a
2
little
seconds.
bit
I
of
have
time.
to
That
check. I
seems so
have to
long.
check. I have to check.
That was great. Where was the enjoyment in that? There was no fun in that.
Okay. Okay.
You used the JR?
No, this is a glide catheter.
Okay.
됐고, 오케이, 와이어 갖고, 피그테일. 나왔고요. 오케이, 아웃.
So, what do you think about the contralateral limb opening? This projection is an AP projection. Do you happy with the opening, or do you have another? Do you want another direction? Even though it cannot be modified right now.
Because you will have the enough overlapping segment, so the angle is not absolutely required. Only the areo projection to see the distal iliac bifurcation for the accurate length measurement.
Okay.
Yeah, we need to see the internal iliac artery.
Exactly. I mean, we really just got to see the level of this gate to the hypogastric.
여기서 그냥 랭스 재고
야.
엔지오로 엔지오
조용히
다 해줘.
When to areo projection?
So you want to go REO here?
Okay. Yes.
You've got a long distance to cover
Yeah.
the hypogastric.
It's
You
too
can
long.
use anything here.
오케이.
Did you change the wire to run the kist?
Not yet.
And yeah, I recommend after change the wire and angiogram, take a angiogram.
Okay. It's a good idea.
Lutein is with the Lundquist wire. Otherwise, it will be different.
와이어서 런더 패스트. 오케이. 아웃. 런더 패스트.
If we introduce a Lundquist wire inside the pigtail catheter, the length can be shortened compared to anatomical tortuous length. Do you think Lundquist should introduce through the pigtail catheter during the measurement, the length measurement?
Yeah, we always do it that way, yeah.
Yeah, that is more accurate in my experience.
Okay.
That's interesting. That's interesting because we were always taught to just do the pigtail without the wire.
DSA 말고 그냥 하시면서.
괜찮을 것 같아요.
Well, I think an REO projection would be better here.
Yeah.
Yes.
Because you don't
This is
really see
REO
the
projection.
bifurcation. 30 degrees.
That position would
At
be
least in this view, it's 12 centimeters, if not longer.
Yeah.
11. Okay.
So 12 124 length is enough. The
Yeah, but we don't really see the bifurcation, right? It's an overlap there.
yes, it's a little overlap.
오케이.
네.
아래로 더 줄까요? 아래요. 아래요 more. 아래요 more. 아래요 more. 아래. 30보다 더.
30, 30.
조영재 어딨지? 이거 너무 작은데? 다이 섞어서 신해
플로어로 해.
Oh, even more.
오케이.
See, the bifurcation is much higher than we thought.
Yes,
Yeah.
you are right.
That seems like short by about a centimeter.
7, 8, 9, 10.
Looks like this small
Ah.
aneurysm is still coming from the external.
Yes.
So it's even higher than we see here. Yeah.
그 위. 네, 거기서부터.
You can look at the
So the
CT
length-
to look for the optimal angulation.
9 or 10. It's 10 now.
I think better to
120가 아니라
120.
better to choose a little longer than you can compress.
12.
Yeah, you can
Yeah,
make
sure.
it short.
Yeah.
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 The short is difficult, but long is better to
Okay.
adjust.
Yes, actually the distance from the contralateral limb opening to the iliac bifurcation is 6 centimeter, 6.5 centimeter, and we're gonna overlap the 3 centimeters. So the length is 100 something. So we're gonna use 124 and make it short during the deployment. 테이블 고정하고.
So this is a 14 French sheath.
Yes.
Yes.
Okay, can you see the overlap drawn?
Now it's here.
Okay, here.
Now I will deploy the segment.
쉬스 좀 잡아줘. 앞에 가서 쉬스를 잡아줘서. 오케이. 아 조심. 네. 오케이
So
거기.
that overlap is, it's kind of critical in the sense that it keeps it from sliding and becoming disjointed, disconnected for a type 1B. But more
Yeah.
importantly, it also gives it the anchoring of where the flow divider is. So trying to hit that mark with the other markers is kind of important.
Yeah, if you implant it too high, then it may go to the other side. And
Exactly, it just occludes the contralateral limb, or the ipsilateral limb in this case.
Okay.
I think this is the highest position, which is
Correct.
possible. You already see that the proximal end is flaring.
천천히 여기서 테스트 한번 하고 갈게요. 네. 아니
이걸로
저걸로 해야지. 쉬스.
다이.
So when you deploy the device, you don't check, you don't mark on the screen.
Yes, we put the marker there. Then I adjust the length with the mark now. I will check angiography again. 네. Okay. We have
It's too
enough
long.
space to.
Yeah, push
Yeah.
forward as you
Yeah.
deploy.
더, more push. 또,
Go ahead, start to
밀고,
deploy.
반 풀고 밀고, 반 풀고 밀고. 오케이.
And now it's above the line in the screen. I hope it's don't touch the bifurcation. Okay.
Good. That was tight.
Safe.
It's close.
아웃으로. 잠깐만 이게 잡고 있어요.
오케이, 좀 빼놓고. 와이어 밀어주고.
아유 밀고 있어.
반대로. 예, 반대.
오케이. 예.
저기가 잠깐만.
와이어. 예.
잠깐
감사합니다.
스탑. 잠깐만요.
네.
빼지 마세요. 플로어로 그만 밟고.
네.
잠깐만. 스탑. 그냥 건들지 말고.
네.
이게 요거가 요로 따라 내려야 돼.
네네.
네. 이렇게. 얘가 따라 내려.
네네. 실수.
실수할 테니까 이제
네.
조립.
네.
풀로 조립. 오케이.
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 네. 오케이. 나이스. 아웃. 아웃.
실수 조금만 빼놓을게.
네.
팁에다 하고. 오케이.
좋습니다.
예.
오케이. Now
AP 주고.
AP.
다시 실수 가서 잡아줘. 예.
네.
디플로이. 아니, 풀 디플로이. 컨트롤
예.
예, 잡고. 예. Okay, now we are going to open the ipsilateral rim opening. Okay. 예. 됐어.
오케이.
예.
세이프.
약간만 전체 올려주고. 예, 오케이. Capture the olive tip. 오케이.
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 And then
예.
예, 실수 꽉 잡아요. 밀려 나오게. No resistance. 오케이. 자,
뺄게.
해주세요. 아웃. And pigtail. Okay. So main body is out now. Next, we are going to measure the length between the main body limb and the right iliac bifurcation.
일레요. 조영제 준비하고. 플로로만 밟아서 그려도 돼.
네. 알겠습니다. 오케이.
조금만. 네. 오케이.
자, 플로로만 밟겠습니다. 네.
또,
너무 다일루션 된다 보니.
Too much dilute.
예.
But we can see.
Can you see the bifurcation?
굿.
Even though Yeah.
Okay.
그 밑에 하나
no,
밑에
no.
하나 밑에
더 밑에.
하나 밑에 예,
네.
거기에 bifurcation. 예. 네.
Okay.
Yeah.
I will check again. The angio is not clear, so just a moment. I will check cine. Okay. Okay, same area. 10, so 12.
So during Dr. Chae measure and the device preparation, Dr. Yoon can remove the pigtail. So quick procedure.
So I count 9. Is that the same as what you got?
예.
Okay, 테이블 고정.
Now the working length is around 100, so we're gonna use 124 ipsilateral limb here. The distal diameter is 16 millimeter. So 16, 124 millimeter of length.
Keep the wire.
So somebody is preparing the balloon.
Yeah. Because of time limitation.
Yeah, takes
Okay.
time. Audience
Okay.
can feel boring during your preparation. So always during positioning, we are ready for the reliant ballooning.
하나 더 있어요. Okay.
Yeah, during measurement, I remove the pigtail and quick, just 1 second. Next step, recommend the assistant to prepare something new.
Now I'm deploying the ipsilateral limb. To make it check position.
Only looking at the distal marker.
Okay.
Now we are outside of the main body, so
I will check again.
little push up.
다이.
반대.
아, 네. Okay. Push. It's sufficient.
Yeah. We don't need to push it.
Ah,
So the
I will
length
just,
is sufficient.
okay.
조금 더 올릴 수. 지금 약간 올려. 예.
There you go.
조금만 더. 예. 오케이. 조금 더.
It should release north, yeah.
오케이.
Okay. 네, 시스 잡고.
와야 되는. 오케이.
Okay.
발론.
Remove the ipsilateral limb device.
이쪽에 발론 먼저. 응.
코다 볼라.
I am still
Will you pause
concerning
balloon?
the chance of under expansion of stent graft and bifurcation rubber. So even though immediate result is good, during the follow-up duration, the risk of early occlusion or the risk is high. So in the follow-up scan, you should check the whether there is under expansion
Yes.
stent graft or not.
Inflation.
Okay.
Why don't you make it one line to not to lose the proximal edge? This is not the horizontal.
Deflate.
예.
Save.
위에
Okay.
점점
RAO. AP cranial. AP cranial.
앵글이요. 오케이. 예.
Okay. Yeah. Now it's in one line.
So this
Deflection
adjoint balloon also should clearly.
오케이.
Okay. Stop.
예.
Are you going to
Save.
perform the kissing balloon at the bifurcation lesion or just to?
Just a sequential balloon. After we're gonna check the angiogram, whether the limb bifurcation area is kinking or compressed.
Inflation.
This is the reliant balloon, right?
Yes.
Yeah.
Deflation.
So you are using only one time balloon in the proximal. This is a high
No, two times.
two times. High chance
Plus
of
two times.
1A this patient. So I feel 1 or 2 millimeter down from the right renal edge.
Save.
Yeah.
Deflation. And then
플러스 콘인데 조금 아까 내려서 디플로이된 거.
AP caudal.
네, 거기서 한번 할게요. 조금만.
네.
네. 아니 바이퍼케이션 한번 하고.
bifurcation.
네, 거기
예.
살살.
Yeah,
네.
that's
오케이.
fine.
스탑. 예, 예.
Inflation.
오케이. 스탑.
Slow inflation, please.
천천히. 예.
Too short inflation time.
Okay. Remove.
I have a question about the antiplatelet therapy. Because this patient has a very narrow terminal aorta and the risk of the leg occlusion is high. So, how about the antiplatelet therapy?
So usually DAPT is needed early in the post-EVAR period. But in this patient, as you can see, the
AP crane.
ugly plaque in the arch and all through the aorta. So I think more than 1 year DAPT will be needed in this patient. And then also we're gonna check the CT angiogram for limb occlusion around the aorta bifurcation area. So Dr. La, you mentioned that this aorta below the renal artery is a reverse conical shape. So the maximal diameter just below the renal artery is 22 millimeter. We chose 25 millimeter device. So I think it's enough to seal the proximal part. And then the narrowed position is a 20.
AP.
So as you can see here,
Okay.
during the balloon inflation, the balloon
Inflation.
shape was a reverse conical shape.
Yes, it's good choice.
Save. Deflation. Inflation.
I usually just stay 1 or 2 seconds at least
Deflation.
Oh, that's
to give a pulse.
Okay. And I will perform the balloon angioplasty, the bifurcation area a little bit.
조금 내려서 내려가세요. Bifurcation. 네,
Okay.
오케이.
Here.
천천히. 예. Yeah, that's it.
Low pressure.
Yeah.
Okay. 천천히. Inflation.
No, this
Okay,
kind of
deflation.
narrow distal aorta
Stable.
bifurcation, we should be careful not to
Deflation.
make an injury in the distal segment. So sometimes
Yes.
the edge event can more
Okay.
frequently.
Deflation.
Yeah, the enemy of good is better, right?
오케이. 오케이, 아웃하고. 얼른 아웃. 픽테일 플레이스.
픽테일. 그 스탑하고 볼론 스탑. 놔뒀어. 예. 픽테일 넣고. 플로를 위에 보여주고.
We've had one stroke from our EVARs, and it was in a arch like this where we weren't paying attention to the distal wire, and it just
Yeah.
embolized from the north. So this is real critical to keep your wire down as you have.
Yes. So
Do you think it was thrombus in your case or a plaque material? Did you check ACT in your case with the stroke? It was normal?
It was normal.
DSA하고 저 환자 숨 참게 만들어주고.
네.
Please control
여러분,
in the
그숨
proximal.
들이셨다가 내쉬고. 자, 내쉬고 그대로 참고 계세요.
Doctor, why don't you
네.
check the one line? As I expected, 2 or 3 millimeter down. So, because the next step, sometimes we need the cup. So,
But in this patient, there's enough length of neck, proximal neck. So 1, 2, 3 millimeter down, that will be okay. And then there's no
Cranial.
endo leak,
If you cry.
as you can see here.
why don't you aspirate in the from both sheaths the 30 cc syringe to improve the distal flow to check the endo leak?
Yeah,
Aspirate
Is it-
during the injection.
But
I think it's good enough. So we don't need to aspirate through the catheter.
The outflow
Yeah.
is very good. So
That looks lovely.
I think it's enough.
That was
Okay,
great.
as Dr. last comment, we had a little bit angulated to the upper level and then right, 아래요. Okay, down.
Sometimes the
Up.
celiac trunk and the
Okay.
SMA disturbing to see the type 1A. So
Yeah, sure. Yeah.
So
But this patient, the celiac and SMA is very big,
숨 들이쉬고
and then
내쉬고.
flow is very good. So I don't
가만히
think
계세요. 참으세요.
there's
네.
you can see here. Okay.
Okay, so the proximal edge is a little bit downward. But
That's
as
very
Dr.
nice.
Chae
Very nice.
said,
Yeah.
it's enough. There is enough neck, proximal neck. So I think we are done.
That's a great result. I
Yeah.
mean, overall, you're anchored on both sides. There's no type 1s. I don't think they stay
Yeah.
on long enough for a
Which one
type
of them?
2, but even if there is, no big deal at this point.
So how much cc volume did you inject for the aorta therapy?
It's 8, and the total 16.
But this damage is 16 cc?
Yes, the total 16 cc.
Because I feel a little bit faint in the distal, middle to distant. We are routinely using 30 cc to definite confirmation.
Whoa. That's
30 cc
too
final
much.
image.
But we are usually we are using the DSA. I usually use 5 to 6, maximum 8 to 10, and then the total
How much?
below the 20 cc.
Okay.
So,
Excellent.
is there any comment?
Are there any questions from the audience or from the
That was a
Panel.
great result.
If not, then thank you very much.
Thank
Excellent
you.
presentation. Very good case. Thank you.
Thank you.
I think we move on to your lecture, Lawrence. That will be a featured lecture about EVAR Update 2025.
Thanks, Horst. Thanks to TCTAP again for inviting me. In evaluating the update for 2025, it was a little bit of a challenge. There's not a lot new. Most of it you probably already know. These are all my disclosures, none of which are terribly germane to this talk. So the definitions, an aneurysm is still a permanent localization of dilatation in the artery. It's an enlargement. In the old days, it was 2 times the natural artery. That's changed a little bit for iliac aneurysms, but focal dilatation of the arteries involving an increase in the diameter compared with the expected normal diameter. And why is aneurysm so important? Well, it goes without saying that as we get older, it's an older person's disease. The prevalence goes up with an average rate of about 2.3 prevalence in the general population for the males and about just under 2% for females. And the change in I was interested in this last case that we just saw where the size was 5.3 centimeters, and still about 2 years ago, they waited till it was around 5.5 to truly take him to the cath lab and fix this. There's this change, or the slope of the line shifts between 5 and 5.5 so that the risk of rupture grows, and that's driven us in the United States to start treating more of these aneurysms earlier at 5 centimeters. And it's all driven by the law of Laplace. As you know, it's dependent on the diameter and really the radius to the square multiplied by pi, and that law of Laplace is what creates the risk of rupture. It's based on the total time of blood pressure, or the rise in blood pressure, and the time of blood pressure shown on that arterial wall. So dP and dt, the differential under that, or the integral under that area, gives you the law of Laplace, which is the overall risk of rupture. 70 to 75% of AAAs are asymptomatic. 30 to 50% on your physical exam are being found. It's an incidental finding on X-ray. And men with less than a 5.5 diameter, the risk of rupture is about 1% per year. And 20 to 25% symptomatic aneurysms are diagnosed each year, and they're principally diagnosed with abdominal pain. It's a little unique abdominal pain, but once they begin to rupture, the risk of mortality can be as high as 3 out of 4. The general statistics, about 5% of the general population have some form of aneurysmal disease. It affects men higher by number in a 4-to-1 ratio to females. 10% of men older than 70% will have at least some dilatation or ectasia to their aorta, and accounts for about 15,000 deaths in the United States per year. It's the 10th leading cause of death in men over age 55 in the United States. And the incidence increases over 300% over the last 30 years, whether it's environmental or other sources, chronic hypertension, it's all debatable. And in the 2000 consensus data estimates that at least in the United States, about 2 million Americans, now closer to 2.5 million Americans, have some form of AAA. And the risk of rupture, when you go from centimeters to 4, it's 2% risk of rupture per year, and that's still not a zero number. So there is always this kind of incremental risk of any arterial rupture for each life year you live. As you go beyond closer to 5 centimeters, it jumps to 5%. But more importantly, when you go 5 to 5.9, it jumps now up to that 25% risk of rupture. And this is the reason for all the guidelines suggesting exclusion, whether it's open surgery or EVAR at that point. The risk of rupture is related to the wall stress, not just the size, so it's really focused on blood pressure and time of that blood pressure. So slow heart rate and low blood pressure are the keys. And the risk of rupture determines when to repair. This is really a guideline that kind of shows us this algorithm. At less than 65, man or woman, you have the multiple risk factors. You go ahead with some screening ultrasounds. Then if there is a family history at age 65 with a history of AAA, you should do this level evidence 1A and should consider, if they've ever smoked, to do the screening ultrasound. And in women with family history AAA, you should screen women just as often as men in those risk factor groups. And over the age of 75, again, you can consider ultrasound. The first endovascular repair, Juan Perotti, really focused on this, and it was basically trying to reproduce what they do in the operating room, which is putting a tube graft in. The fixation was a bit intuitive, but not terribly useful, at least in the first series, the Gen 1 device. But what about medical therapy here? So medical therapy, our target blood pressure is 130/70 now. It's a class of level of evidence B, class 1. Hyperlipidemia, target the LDL under 70. I'll show you some data on the statins. It's a class of level 1, level of evidence B. Tobacco cessation is absolutely necessary, again, class 1 indicated with a level of evidence C. And then antiplatelets, whether it's aspirin or other, but generally with aspirin, it's a class 2B indication with a level of evidence C. Statin therapy for AAAs, we know that it works for coronary disease and peripheral vascular as well as carotid disease. In the European Journal, back in 2006, 130 AAA patients followed for 2 years, 75 were taking statins, and there was no change in the aneurysm for 2 years. Follow-up study at 150 aneurysms. Statin use was associated with a significant attenuation of AAA, but the statin users' lower annual growth rate of about 1.16 millimeters versus 1.99 millimeters compared to those on placebo. When they did a larger study, this was back in 2010, 652 patients with surveillance ultrasounds of AAA at 5 years, there was no association with a decline in LDL associated with AAA. So it's really the level of evidence, although it's a class 1 indicated use of that drug, still a bit murky water when it comes to how it performs when it comes to your AAA growth. Blood pressure is really the key here for limiting your law of Laplace. And so this is a retrospective review, but ACE inhibition does indeed improve, because of vasodilatation, the risk of ruptured AAAs. What about open versus surgical repair? This is the old data that all came from Juan's original work, and that is that back in 1978, just like Andreas Grunzig thought that angioplasty would supplant open surgery. This is a true statement in 1978 with the opportunity to do what we just saw, which is outpatient EVAR therapy without having to do an open abdominal procedure. These are all the current devices that are available in the United States. I put it up here. It's a little bit busy of a slide, but it really does show you across the board, most of these stent grafts are very flexible. Some have pros and cons. The biggest issue is really how big the device is going in, and the average rate has gone from bigger to smaller, but the standard size is around 15 to 16, and then in many cases the main body is still 18 to 20 French. So you just have to be aware of what you have, what you're trying to get into from an arterial standpoint, and how that will perform inside the body, both by length and diameter. If you want to really know the data between open and closed procedures, the 3 big trials that came out in the mid-2000s are the DREAM trial, EVAR-1, and OVER trial. 330 patients, 1,250 patients, and it's a VA cohort study in OVER with the benefit of EVAR showing no significant difference to open repair. That's the critical part to all of these trials, and this is why EVAR's percutaneous aneurysm repair with these stent grafts has supplanted open surgery in many cases, if not all cases. These are the quick data points on EVAR showing no overall proportion of mortality over the 4 to 5 years, no difference between open repair and EVAR. When you look to first re-intervention rate, the open repair still by definition has a better outcome because they seal off all open arteries at the time of their open repair, as opposed to having to do subsequent procedures, whether it be type 2 endoleaks or limb issues following the placement of your EVAR graft. The DREAM trial came out in the New England Journal, and this was back in 2005. Again, endovascular repair, when it comes to probability of any severe events, you know that it's a less morbid condition compared with an open surgery, and this is why, again, this outcome was so important when it came to original EVAR data. And then the probability of reintervention clearly favors open repair, again, being able to take care of all those secondary arteries at the time of the open surgery. It's a randomized trial. Within 30 days, the difference between mortalities was really in favor of the EVAR compared with the open repair, and after 30 days on, again, still in favor of the EVAR system. When it comes to the perioperative outcomes, this is from my old colleague, Mark Schermerhorn, on a CMS database. You can see that the death rates, our mortality rates are clearly in favor of the closed design of percutaneous aneurysm exclusion as opposed to an open repair. And if you look at survival with endovascular repair versus open repair, again from the CMS database, you can see that overall the mortalities tend to crisscross later in life, but the benefit of early mortality, the so-called M&M event with open repair, is in favor of the EVAR approach. From 2012, survival after open versus surgical, endovascular surgery clearly has a benefit compared with the open repair again. So you have 5 real big trials which demonstrate aneurysms still work. Or can be excluded by way of EVAR very well. These are the types of endoleaks. Type 1 is leaking from the primary source of anchor, either proximal or distal, and this is still a direct pressurization of the aneurysm. The type 2 endoleak, which is the most common source, is retrograde through the lumbars most commonly. Fabric defect is a type 3, and then fabric porosity over time would be a type 4. I think the biggest improvement over the last several years has been fenestrated grafts, modular components with predetermined locations. They're actually 3D reconstructed, specific for the patient. There is off-the-shelf stuff with cupping of the SMA that you can use, but really these branch endografts really do allow you to do further work in that territory of the perirenal area to allow you to exclude the aneurysm and still maintain flow to these very critical branches. These are pictures from my friend Sean Lydon at the Cleveland Clinic, which shows how you can now go suprarenal and still maintain patency to these major branches. And then, of course, the iliac bifurcated branch designs are very nice to be able to take an aneurysm through that iliac bifurcation into the internal and external and still maintain at least one hypogastric as you work forward. So in conclusion, I think that the update for 2025, EVAR remains a primary method for exclusion of aneurysms today, much better than they were even 15, 20 years ago. The advancing technology resolves many of the problems both by access, endograft durability, and endoleak repair, and branch preservation, which is really the critical change over the last 5 years, has become much more mainstream. The percent of patients untreatable by EVAR and percutaneous approaches, I think, is going to approach 0, if not already at a close number to that. And the long-term outcomes remain the challenge, best followed with either serial ultrasounds, CT scans, and more importantly today, AI is now demonstrating how it can help guide us in whether or not our aneurysms are getting larger or the sac is actually shrinking. So I think that's going to be a future helpful aid to us when we treat our aneurysm patients. Thank you for your attention.
Thank you very much. So the threshold when to intervene is kind of a moving target. I remember that years ago it was 5.5 centimeters, then it was 5. Now you tell me it's 5.5 again. So is it in the guidelines already 5.0?
No, I think, yeah. So I'm not sure in the guidelines it's switched down to 5. I think that, you know, I didn't put it in there, but the British did this small aneurysm trial. It was a 4.5 to 5, and there was no benefit to doing it early. It was more costly, and costly meaning more morbidity. So I think that shifted everything back to that 5.0. I don't think you would be faulted for waiting to 5.5, but that shift between 2% and 5% is a real shift. I mean, it's 2.5 times the normal average. So by definition, at least in the United States, when it gets close to 5, we go ahead and pull the trigger on
What's
repair.
about aneurysms about 5 or 4.9, but they are eccentric? Is that something which changes your indication?
I looked at that, and you guys can correct me if I'm wrong. You know, I always call it a seated, you know, if the angle is tight, or it looks like it's a pregnant woman, right? So the posterior side is still thick, but the anterior wall is very thin. I've always believed that those have a higher risk of rupture. The data doesn't support that. It's hard to prove that. But the gestalt, my perspective on that would suggest that it is still a higher risk, and I would probably pull the trigger on that sooner than not.
With these data available, are you still discussing surgery as an option with your patient? I mean, a realistic option?
Yeah, I think that, before we had bifurcated stents, I think I would send patients to surgery for the perirenal more often just because of debranching and that kind of stuff. I think today I don't have that discussion. And the challenge, again, for my surgical colleagues, for those of us with gray hair, we can do a lot of stuff with catheters. The surgeons with gray hair are the only ones who have been in a belly. A lot of the surgeons coming out of training today haven't been in an abdomen. They've done everything by EVAR. And so the ability for them to get to an abdomen and really open it and do really good work, I think is a challenge. At least in the United States, it's a huge problem for me to find people who are even willing to do that.
Any other questions from the panelists, from the audience?
Relatively many kind of devices available in USA. So do you have any personal guideline when you choose the device in EVAR procedure?
Yeah, I think that, like most things, you get used to what you like to use. And so I'll use two devices primarily. As a cardiologist, when I started down this road, I really gravitated toward the smaller lumen device, which was the old Ovation stent. And now it's taken over by Endologics. And then for the standard, I really like what they used, which is the Medtronic device. I like suprarenal fixation. I like the Ovation because it has no outward flow, outward pressure. That neck can change because of outward pressure. So I think they both have some things. But, the Gore device and all the other devices that are out there, I think as long as you're comfortable with it, I think any one of them work, and they all have their approval. So, I can't say that I've had experience with any of those other ones.
Where did you put the contralateral leg?
What do you mean?
When you implant the device, where did you put the contralateral leg?
It almost always, in my cases, I almost always crisscross them. It just seems like a straighter shot.
Okay.
I had one case not too long ago, about 6 months ago, where I did the crisscross, and the contralateral limb was an Ovation stent, Alto now, and it flipped open, and it opened right into the thrombus of the wall. Oh. And they have this wire system that allows you to cross down from the ipsilateral limb, but it went right into thrombus, so it never cleared. So I had to come from the brachial to then, get through the damn thing. So sometimes it works and sometimes it doesn't. But
okay, if there are no other questions, thank you very much for attending this session, and enjoy the rest of the conference. Thank you.